Well, thank you again. I want to thank the ESR and Waleed for the kind invitation to be here in Dubai again. I think the ESR has put on some great meetings in the past. I'm a little worried about the Academy's initials. I'm thinking of starting my own meeting called CRP, the College of Rheumatology Professionals, to compete. But you do have the best sort of group name. I like that. So I'm going to talk about vaccination. I'll mention Room Now Live. It's my meeting that I run with Artie Kavanaugh every March. You can come if you want to come to Fort Worth, but you don't have to. It's all going to be streamed live, and registration for this meeting is available probably starting about 3 weeks before the meeting. Right now, we're only registering people who are going to come to the meeting and attend the meeting. But I think if you look at roomnow.live, you'll see the program. I think you'll like it. It's very interactive. We're going to try to have more interaction with the people who are viewing remotely. So the whole issue, isn't it kind of interesting that we as rheumatologists have to have some degree of proficiency in vaccinations? I mean, it's a really important part of what we do if we're going to do it right, because one, it's the right thing to do, but it's also the best defense against what patients find offensive, and that is the whole issue of infection. You don't have direct-to-consumer advertising as much, I think, here as we do in the States. Patients are constantly reminded that the biologics and the drugs that they take are, will cause them to have infections and die, and don't take this if you have infections, and so that's what they're really worried about. It's a major impediment to adherence, compliance, taking the medicine, and feeling like they're going to be safe on the medicines. In fact, I tell patients that are on not just biologics, but even methotrexate, somewhere, usually, I'm doing it a lot earlier now, but I tell them sometimes 2-3 years later, hey, the risk is over. All the risk as far as infection and all the ugly stuff with biologics and whatnot, it's front-loaded. It's first 6 months. When someone's on Enbrel in year 4 or on Actemra in year 2, the chances of an event go way, way, way down. And that's and the same, by the way, you should do this with all your patients with methotrexate. But nonetheless, I think that, managing infections, you have to, number one, manage the disease. And that includes the comorbidities. And I'll say the biggest offender here is chronic lung disease. That causes more trouble in rheumatoid arthritis than any other comorbidity. Rigorous patient selection. There are many patients who should get these drugs, and there are many who shouldn't. If you want to know who they shouldn't, go to this website, biologica-register.de. This is the rabbit risk calculator. You can put in, click, 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 and find out what that person's risk of infection, serious infection, is in the next year. Minimizing steroid use, monitoring the patient. Lymphopenia, WBCs are important factors. Screening measures are really important, and vaccination to reduce risk. And then lastly, educating your patient about infection with rules about when to worry, when not to worry, when to call. I tell my patients, it's my drug, I'm letting you use it. Nobody else messes with it. The pharmacist, the ER doctor, their family doctor, their neighbor who's a pediatrician, everyone thinks they know what they're doing, and they don't, because they're getting in the United States, they're getting all their education from television, from a 60-second ad. That's it. They don't know the data like you know the data. So the point is that there are people who are very high risk, and you know what those risk factors are. And the question is, how do you get them a very low risk? And I think it's by testing, monitoring, weight loss, patient selection, and then vaccination, and then screening for TB, and then treating TB when it's an issue. So does it work? It's always labeled as one of the top 10 public health achievements in society. I mean, it's the data is overwhelming. The diseases that have been that are no longer around, polio, measles, rubella. Well, we have some measles outbreaks in the United States right now, but these are people who didn't get vaccinated. And the problem is that there's a lot of idiocy about the dangers of vaccines. We call those vaccinots, that they're not going to take those vaccines because of what they read on the internet, which has been proven over and over again to be vastly untrue and not based on any science at all. So it has been associated with increase in life expectancy. We do know there are situations where now some teenagers are not getting the HPV vaccine And what's going to be the long-term consequence of that? You know, and we'd like to talk about the dangers of that, but we're going to have to wait a number of years before we actually see that come to fruition. This is part of the problem with vaccine research. It's really hard to design trials because the endpoints are remote, and trying to actually get a properly designed trial is really a hard thing to do. And then immunogenicity is basically your surrogate for efficacy, and that's kind of really unsatisfactory. This is I think a quasi-effective way of showing that vaccine may work. This is 500 patients with either SPA or RA, and this is both combined. And you can see those who were vaccinated, those who were not vaccinated. This is against pneumococcal vaccine. And you can see, again, that the vaccinated, the orange ones, are generally less than the green ones, but mainly look at here at SI, serious infection. That's where it seems to be more striking and maybe more valuable. So there really is evidence that says that this does work. There's sort of indirect evidence like this. This is a large UK database, 30,000 patients, that looked at those who actually did receive influenza vaccine, and while they didn't show anything as far as what you like to see, influenza events and pneumococcal events, they looked at basically death and death from pneumonia, and people who were vaccinated actually had less death and had less death from pneumonia. So does that mean that vaccines are generally a better patient, someone who's more health conscious and more likely to follow your advice? It's not known. This is old Doran data from almost the pre-biologic era at the Mayo Clinic, showing that rheumatoids have a higher risk of pneumonia, skin infections, bacterial sepsis, septic arthritis, and osteomyelitis. Actually, the same can be said for other common infections, including influenza. So this shows you rheumatoids being in black here compared to age-matched controls. Again, it's higher, including those who are not on DMARDs or biologics. Complications are higher as well. And over here, I think it says basically the same thing, that rheumatoids get more infections and then complication from influenza than do their matched controls. The problem is you, me, even University of Pittsburgh personnel, we all stink at actually getting our patients vaccinated because it's not worth the fight. You want your flu shot today? No, I'm gonna get it at work, or no, I don't do it, or everyone's got a million excuses. But the data is very, very clear. There's a whole bunch of studies that basically show, and by the way, you're not any worse than internists at doing this. If we had Anthony Fauci here, the head of the infectious division at the NIH, this is what he would want to talk about how we are so bad at actually vaccinating our patients, and it's the one thing that he knows will work, but yet we don't do it. And I'll tell you that I used to say that, how do I deal with this in my clinic? And we did this for about 2 years in a row. My nurse practitioner and I, we made everybody do it. We forced them, we argued with them. They said, no, I don't ever get vaccines. I said, what if I give you $12? And they were like stunned, like, what are you talking about? Like, you're crazy, And I said, okay, it's now 15, what's it gonna take? And so then usually what happens is an argument or a discussion would ensue. Well, the interesting thing about this is that I just changed my job, my employer. I'm back working with the University of Texas, and I'm using a new EMR, which I truly hate, Epic, which is a gigantic waste of time. But it forces you to do a whole bunch of things. And my clinic is really good at people getting vaccinated. And not just against influenza, which is what I'm really hammering on right now. In Dallas, we have more deaths from influenza than we have people in all the United States who have been infected with the coronavirus. But yet everyone's talking about the coronavirus like it's the next thing that's going to kill everybody. So we need to do better at this. You need a strategy to deal with this. You need to be willing to spend the time. To assume your internist is going to do it is probably a foolhardy sort of hope. Again, it's one of the great things that we're not very good at. Influenza and pneumovax vaccination, public health studies. I actually have another study with Jeff Curtis and myself and Kevin Winthrop showing we're not very good at that. We're also not very good at other things we should do, including checking lipids and whatnot. This is basically showing you the vaccination deficit. So here you can see that there are people, you know, it's not too bad. This is the uptake here is 63, 70%. That's pretty good. You know, it's not so good for pneumococcus, by the way. I don't know if I believe all this data, but nonetheless, that's pretty good. By the way, we tend to be really good at getting vaccinations in people who you don't have to work very hard at. That's the elderly and the people who are very sick. You know, it's the young people who have basically less than 20% vaccination rates that are hard to convince. I must say, I do back down when someone says, no, I don't get it, I've never got it, and I've never had the flu, and they're a very well-controlled rheumatoid with no comorbidities. It's not worth getting into a fight with, you know, with that person. But everybody else is fair game as far as I'm concerned. Are we getting better at vaccination? This is looking at different time periods, starting in 2006 and going to 2012, and whether people are actually getting the seasonal flu vaccine. And look, boy, it looks like, you know, if there's no other reason, because with the other reasons we've been doing it all along, that's like elderly and you know, immunosuppressed and just get out of the hospital or whatever. But, you know, just having the disease, whether it be RA or SPA or even lupus, we are getting better over time, according to some studies. And that's encouraging. So I think the one thing you need to know about flu vaccine is probably two factors which were presented, I think, 2 or 3 ACRs ago. And this is based on Park and colleagues in Korea did some preliminary work trying to figure out whether the timing of getting the flu vaccine and using methotrexate. And they studied it in all kinds of ways, and rather than go into this in much detail, the bottom line is that you should be off of methotrexate for 2 weeks. Number one, it gives you, because methotrexate, of all the drugs that you use, methotrexate is probably the one that most impairs seroconversion. It really blunts it, and so when you're, you know, if you're on a TNF inhibitor or on an IL-6 inhibitor or, you know, on a JAK inhibitor, that won't affect, you know, the success of vaccination hardly at all. Rituximab, oh yeah, that's going to, because you're knocking out B cells, right? But basically all the drugs, but then add methotrexate to the mix, it really screws everything up. And it's the only one of all the oral DMARDs that will do it. So again, someone's on methotrexate, you get your vaccine and you skip the next 2 doses of methotrexate. It's not enough for you to flare RA-wise, and it is enough to give you an optimal response to seasonal flu vaccine. The other thing is, should you get the standard dose vaccine or the high dose, the flu zone, these sort of things? And there's a number of different high dose regimens. They've generally been advocated for in the elderly, but turns out they are probably more indicated in your patients. So a McGill study that was presented at the 2018 ACR looked at almost 300 patients. They looked at 2 different flu seasons. They either used standard dose or high dose quadrivalent flu vaccine. The primary endpoint was seroconversion. High dose vaccine showed a 2 to 3-fold higher seroconversion rates compared to standard flu vaccine. I have standard flu vaccine in my clinic. It's no problem that we can pump that out all day long. I don't have the high dose stuff. Maybe I should, but it's more expensive, it's harder to get. Right now I would say still, even though I have this information in my head, and people are asking me what should I get and where should I get it, I say if you have RA, get the high dose stuff, go to a local pharmacy like CVS or Walgreens, and they'll be paid for by your insurance. The problem is that they actually looked at this in a number of different treatment groups, and they kind of mixed them together, like they mixed abatacept with rituximab, and that group didn't do very well on these high dose responses, but it's the rituximab that screwed up the results there, not the abatacept, because you wouldn't expect that from abatacept. So cost and availability is the issue, but again, this is really probably the right way to go in patients who want to protect against flu vaccine. The time to give flu vaccine is September, October. January is the peak month on influenza, and it starts to come down after that. By the end of March, you're pretty much done with the flu season. So I'm still vaccinating people this month. After this month, we'll stop in our clinics. The only contraindication for receiving flu vaccine is anaphylaxis. The ACIP, the division of the CDC that comes out with guidelines every year, has basically said all the things that you worry about are really non-issues. So first off, the seasonal influenza vaccine does not cause the flu, all right? It's felt that most of those events are people who were getting the flu as they got the flu vaccine, so they no time for it to actually help. The other issue is people confusing, the constitutional manifestations and soreness of the flu vaccine with having the flu. The idea that it causes Guillain-Barré has sort of been disproven. Recurrent reactions are rare, meaning that you have a reaction, but then it kind of goes on and get future reactions. That doesn't really happen, although people make that claim. And then egg allergy used to be the big thing, and that turns out to be not true either, although for people who are really freaked out about it, there is an egg-free flu vaccine called Flubot. So the big issue in vaccination is live versus inactive viruses, and everyone here is well versed with the idea that you don't use live attenuated vaccines because there is a potential there to cause a disseminated infection, especially someone who's immunologically naive to what you're using. The most commonly used live vaccines that could be a problem could be the Zostavax or the Flumis. This is influenza, and this would be herpes zoster here. Whereas it is safe to use the inactive vaccines in all your patients, no matter really what therapy they're on, whether it be a biologic or a DMARD. So we'll use zoster as our best example of what we're dealing with here. So again, zoster used to be the live virus vaccine that we all worried about. Other ones that you have to worry about would be the nasal influenza, that's the Flumis, which is actually not available much anymore. There is an oral typhoid that is live virus, but there is an IM typhoid that is inactive. So that can be helpful in some situations. Yellow fever is a live virus. MMR is a live virus. BCG is a live virus. The only thing I want to say about that is your patients who have bladder cancer, who are taking intravesicular BCG, are at high risk for getting TB and reactivation of TB when they're on BCG if you have them on a TNF inhibitor. Not other biologics, just the TNF inhibitors, okay? So someone getting BCG, you got to stop a TNF inhibitor, move on to an IL-6 or an abatacept or a tofa, and you're not going to get into trouble there. Polio, smallpox, rotavirus, this is important in kids. The rest of these are all inactive, and that includes DPT, the pneumococcal vaccines, the hepatitis vaccines, HIV, meningococcus, even rabies, and if there is really a Lyme vaccine, I'm not sure there is, although they talk about it. So, shingles, 1 million events per year. Everyone in this room has a 1 in 3 lifetime risk of getting influenza. We are all assumed to have chickenpox virus in us, even though you may not remember ever having had chickenpox. It's rare to find an adult who hasn't actually have evidence of prior antecedent infection. So again, you don't have to test people to see if they have been infected before. It is a devastating sort of rash, severe pain. You'll get postherpetic neuralgia in 15 to 20%. Ocular involvement, ophthalmic involvement is very rare, but devastating. Disseminated disease also very. So this is what happens in the general population. The risk is per 1,000 people, and so young people, it's like 2 to 3 cases, and then when you get up to 50 here is when it starts to turn into a number that people worry about, and then 60 is much higher. It's 6 per 1,000, then it gets higher when you get older. Postherpetic neuralgia is more of an issue with the elderly, okay? So I'm now going to show you what it looks like in your arthritis patients, right? First, TNF inhibitors, comparing these are 6-7 population-based studies showing you that RA patients on TNF inhibitors have a 1.5 to 2-fold higher risk of zoster, okay? That's all comers. I wrote about the zoster vaccines and whatnot, and I love this title, if you don't fear the infection, you will not value the solution. That comes from one of the quotes that was at an ACR seminar on this. And it's very, very true. If your people don't fear the infection, they won't value the solution. And these are solutions. I already gave you this data. The population data is about 4 to 11 per 1,000 patient years. But look over here. Normal people, let's say 4. Osteoarthritis, meaning kind of elderly, 10. RA is about 14, 15. Lupus is about 20, 25 per 1,000. GPA, 43, assuming GPA patients get, and I would assume myositis patients, that the drugs we use, high-dose steroids and other steroid-sparing drugs, also elevates them somewhere above lupus or maybe below here. But if you look at the JAK inhibitors, the rates are roughly above 40. Now, the makers of those drugs say, hey, a lot of that came from China and Japan, where they have a higher risk. If you take those people out, the numbers are more like 30 or whatever. No, you should think of them as being these numbers. So I don't tell all my patients to get vaccinated against zoster if you have RA, but if you have RA and you're going to go on a JAK, I get everybody vaccinated ahead of time if I can get it paid for and if they're over the age of 50, right? It's a reflex here because you're going to see a lot of it no matter what. And it's good to do it before, but you can, because the new virus, the new vaccine is inactive, you can actually wait until even when they're on the drug and do it. So the new vaccine, the first vaccine was approved in 2011. It's Zostavax. This is a live virus vaccine. It's not intended for use with acute zoster or patients who have post-herpetic neuralgia. It gives you about a 51% protection against that, and about 2/3 protection against post-herpetic neuralgia. The problem is it works. Those are numbers for like people 50 and 60. When you start looking at 70s and 80s, the numbers get cut in half. It's not quite as effective. And it's only been proven to work for 4 years, but probably works for as much as 7 years. That's important because if you have patients who had that 4 to 7 years ago, maybe they're candidates for the newer one, okay? The ACIP, it's been studied and approved for use at 50, but it's only, in the United States, only covered at age 60 because there's not enough people here and more people here. They don't want to pay for it. There were shortages. The ACIP went along with this recommendation, but that's changed over time, especially with the introduction of the new live inactive virus. So can you use live virus vaccine in people on biologics? I did a survey of 200 rheumatologists and showed that, and these are 200 who responded by saying, yes, I have a patient with rheumatoid or psoriatic or AS arthritis who inadvertently received Zostavax, the live virus vaccine, while on a TNF inhibitor. And nobody had reactivation. There was one patient who had a blistering rash. So that was my own experience. We did as a poster. This is Steve Lindsey from Oxford Clinic in New Orleans. He did the same thing. He had, 110 patients who all got Zostavax and nobody developed dissemination or reactivation, right? And then we have the VERVE study from Jeff Curtis and Kevin Winthrop, which looked at Medicare claims for a lot of patients over here with inflammatory disease. This is the incidence of herpes zoster. They found 600 people with these diseases who were on a biologic and who had received a varicella zoster vaccination, and there were no claims made for acute herpes zoster. So, and why is this? Again, the idea is that don't use live virus in patients on immunosuppressives or people who are profoundly immunosuppressed. It really comes from pediatric data, where the child who that vaccine would be a neo-immunization, right? And they have a stunted, blunted, not working immune system because they are getting chemotherapy or they have renal failure or whatever. There's a lot of cases in the pediatric literature of reactivation when live viruses are used. It almost never happens in adults because in it's not a neo-immunization, it's a booster, basically, vaccination. So you're already sort of protected against that, so I wouldn't freak out about this. I wouldn't do a live virus vaccine. I would stick with the FDA and other regulatory agencies who are giving you guidelines, but it's not that big a deal if it happens. Now, there is this new Shingrix vaccine, which is an inactive vaccine that has an adjuvant. Studied in, again, about 38,000 people, the Zoe 50, adults over the age of 50, the Zoe 70, adults over age 70, 90 plus efficacy, no loss of efficacy at 70, 80 and above, 90 plus, really 95 plus, 95% plus ability to prevent post-herpetic neuralgia. The problem is that there's a fair amount of constitutional symptoms and local muscle pain, injection site reactions. And the paper says 30 to 70% of people get these symptoms. In practice, hardly any of my patients complain, but when I talk in an audience like this, it's usually the doctors who took the vaccination say, oh man, I was a mess. So I think doctors are crybabies probably, and patients are tougher. But in clinical trials though, they collect everything the patient says. They sneeze, that would be a side effect. And so it's always a little bit of hyperbolic as far as what the true incidence of these reactions are. But you do get it for the first and you do get it for the second. It's 2 doses. The second dose must be given 2 to 6 months later. And the cost is about the same as the Zostavax, okay? Now, we had a problem in the United States where you couldn't get the second injection. It turns out that's about almost 90% as effective if you just give them one. And so I don't hammer on my patients to say, you must get the second, even though it wasn't available. The CDC and the ACIP does prefer Shingrix over Zostavax largely because of the magnitude of response, the durability response. We don't know about the length of response being any different, but certainly it works higher in the elderly who probably need it more is certainly a big issue. Zostavax and Shingrix may be used in adults who are taking low-dose immunosuppressive therapy, have anticipated immunosuppression, and have recovered from immunosuppressive and immunocompromising illness. So the old rule, and this is important for you if you have to use Zostavax, there's a rule that says, the CDC rules say you can give this live virus vaccine people on DMARDs and steroids. No problem. Again, the pharmacies say no, and people think they know what they're saying and say no, but that's not true. You can actually safely receive it if you're on cyclosporin and Areva and triple DMARD therapy and whatever. Yes, it should be avoided with biologics, but if you're going to be using it in someone on a biologic, you either give it before you start the biologic and then you wait 2 weeks, all right? If you're on a biologic, you must be off for 4 weeks, then vaccinate, and then wait 2 weeks to restart, at least 2 weeks, maybe longer. So, but it doesn't make any sense to stop someone from taking their biologic because they want to get the Shingrix vaccine, or sorry, the Zostavax vaccine, the live virus vaccine, right? It doesn't make any sense. Wait until they have an interruption because they go off of the drug for some reason, they have changing therapy, they're having surgery, whatever, and then use it there and then restart it. However, the rules have changed toward here. And by the way, there are really no studies in either of these situations. Both the makers of these drugs, I think it's Merck over here and GSK over here, have flat out said, we're not studying arthritis and immune conditions. No. We're going to make billions of dollars just doing what we want to do and let them figure it out, meaning let you figure it out. Again, there are very few studies actually done over here, none over here. So what I've learned is that it is okay. The real concern here is that because it's an adjuvant, it may be a bad thing to give to someone who has an exuberant humoral response. Rheumatoids and lupus patients, giving them that adjuvant could throw their disease into a tailspin. Well, there's actually really no evidence of that, and I'll show you data for that. Lenny Calabrese yells about this all the time, but he's doing it largely to get the attention of GSK to hope that they'll do some studies, right? Same thing for Bing Bingham and Kevin Winthrop, all the guys that are really interested in this. I say it's okay to give to your patients. If they're on a DMARD or they're on a biologic, I don't care. I like to give it before, but I'm not really going to make a big deal about it. I give it to them while they're taking it. If they're going to start a JAK inhibitor, take it before, or let's do it 6 months in when we remember to do it. So it doesn't really matter. I have no reports of anyone getting best. 1 shot is better than none, 2 is best. This is the data from this year's ACR. In Memphis, they had 47 patients. You could take a picture of this. It's basically nothing happened. At the Brigham and Women, Mike Weinblatt had 400 patients who received the herpes subunit vaccine. There were a few flares, and over here they said flares were 6.7%, right? In the BRASS registry, which is they were studying, their usual flare rate in a year in RA is 30%. So it's not any higher, right? So again, I think you can safely use the Shingrix vaccine in your patients. What does vaccination, how does it work when you're on the drugs that we use? What drugs are going to affect the outcomes? We know RA patients have much lower responses than do controls to any kind of vaccination. Humoral responses to flu and pneumococcus are not affected by prednisone, TNF inhibitors, or abatacept. You can throw tofacitinib and a bunch of others. It is very blunted with methotrexate and very blunted with rituximab, right? That's a well-known fact. And everybody knows about do not use live viruses. Neoimmunization I talked about, Zostavax would be a booster. MMR would be a booster for most people because they've already seen it. Yellow fever is even a booster. But again, giving these to the very young, it's not going to be a booster, it's going to be a neoimmunization. This is just a nice slide that was actually made up by Pfizer in a panel that we were working on with them to develop a slide set. You could probably get this slide set on vaccination free from Pfizer, from the Pfizer website. It's called CARES, C-A-R-E-S. The CARES, and they have a nice slide set on pregnancy that I was a part of, and also vaccinations that I was a part of. Anyway, this is a compilation of data, and we had a lot of really strong people on this committee, but shows you, with using an inactive flu or pneumococcus, no effect with antimalarials, azathioprine, corticosteroids, leflunomide, or sulfasalazine. However, methotrexate uniformly gives you a reduced response. With biologics, again, no effect, including the tofacitinib down here as one representative JAK inhibitor. On the other hand, rituximab clearly blunted the responses. So that's very helpful in you knowing what's going to happen, and that's why you should you stop methotrexate when you're giving other vaccines? I have no data other than what I showed you for the flu. But if you want, you might do it for Prevnar 13 or the Pneumovax. It wouldn't be unreasonable. Rituximab, this shows you a number of different immune responses to these are pneumococcal. No, this is actually influenza strains. And here the healthy controls: RA on a TNF inhibitor and RA on rituximab, all blunted by rituximab. Sierra is a study of what happens when you give vaccination to people going on rituximab in a clinical trial, and you can see that the patients who are on methotrexate do the worst. Rituximab and methotrexate does actually, this does the worst. It's much less than on methotrexate. And we know methotrexate is already a problem. So it's fairly well documented. This is showing you basically, well, let's move on with this one. So there are two pneumococcal vaccines. Pneumovac's been around a longer time. This is called PPSV23. It's a 23-valent vaccine. And Prevnar 13, PCV 13, this is more recent. I think Pfizer makes that. We need both, and timing is crucial. This is what you need to know about how they do the timing. Immunocompromised adult who's not been vaccinated before. They get Prevnar 13 first. You wait 8 weeks. Then you give the PPSV23 Pneumovax. Everyone knows that Pneumovax can be given a second time 5 years later. Could be 8 years later, 10 years later. Beyond that, no more vaccinations. 3 shots, you're done. Wait, what if my patient with RA or lupus has already gotten the Pneumovax, the PPSV23? You're supposed to wait a year before you use the newer Prevnar 13, PCV 13. And then the same rules apply here about waiting 5 years until you go back to PPSV 23 again. If you're going to go and do this, you have to wait again 8 weeks, but that generally is not an issue. So the rules are pretty simple. It's do this one first, wait 8 weeks, then 5 years later. And again, if you're starting out differently, you just have to wait a year before you do the Prevnar 13. It's really confusing, but that's as simple as I can make it. Hepatitis B, everybody should be vaccinated against. We should be testing for hepatitis B, including for surface antigen core antibody, surface antibody. It's helpful in trying to figure out what to do with test results when they come back abnormal. But the ACR recommends that everybody be vaccinated with rheumatoid arthritis against the hepatitis B. It is an inactive virus, all right? It's a series of 3 shots. What do you do with hepatitis B and what it means to patients and why you should be worrying about this? If you're Hep B surface antigen positive, this is what gives you the highest degree of risk, especially if you're on a TNF inhibitor or a rituximab. I mean, it's just very, very high here. I don't know if it's really, I think this really shouldn't be here. The people who are at low risk in general are people who are negative for the core antibody, surface antibody, and surface antigen. That means that you can do whatever you want here as far as therapy. But the people who have a positive core antibody, those are occult infections or resolved infections. They are B surface antigen negative. The question is, do they have LFTs or a positive PCR for viral load. And here, these people are higher risk. Over here, they are lower risk if they have no viral load and normal LFTs. So I can give these people fairly safely with about a 1-2% risk of reactivation, TNF inhibitor, abatacept, tocilizumab, etc. I don't give them rituximab. And over here, you can pretty much give them anything. But again, there's a lot of studies that show the risk is at less than 2% when you treat these people with biologics. This is the schedule. I cut out a bunch of things down here. We don't do in adults, but you can see that basically everyone should be getting the flu vaccine regardless of your age group. Everyone should be getting DPT and be updated. MMR is an issue we'll discuss next. Zoster we talked about. HPV is for your young lupus patients. And again, pneumococcal vaccine is certainly indicated in your adults over age 60. Can you give multiple vaccines? You can give multiple inactive vaccines together, no problem. That's what happens when you join the military. They shoot you in the arm with a gun that gives like 19 vaccines in it, including a few live ones. But research does say that if you're going to give a live one, you can only give one live one at a time is what the rules are. What do you do about the vaccinots? Again, you have to tell them about the data, and you might even want to reprint some of these out and show, look, it's been looked at many, many times and disproven that this is really not an issue. How much time do I have? Or am I done?
I think we have
Okay. All right. Should lupus be vaccinated? Yes. It actually works well in lupus. And MMRs, everyone wants to know about this. There is basically little to no risk for if you have a household contact who's getting an MMR and the mother is or father is on a TNF inhibitor, it's almost no risk. You don't need to worry about it. If they develop lesions, then they cover up and send them to camp for a year. No, I'm only kidding. So they cover up the lesions, stay away from them for a little while. You don't need to do anything more about that. I'll leave you with that. And do we have time for questions or no?
You have 5 more minutes.
4 minutes?
You have
Okay.
5 more minutes.
5 more minutes. Oh, you misled me. You misled me. Okay. So what my practices are, everybody gets a seasonal flu. And again, if you're going to do rituximab, you really have to vaccinate whatever you're going to vaccinate against before you give rituximab. People on rituximab who have very low B cell counts or even very low IgG levels, you can actually vaccinate them, but you have to give a booster like 2 or 4 weeks later, and then measure titers if you can measure titers. And that actually has been shown to work in cancer patients. Pneumovax for high risk, aged, those on steroids, and that also includes Prevnar 13. Zoster, I think I told you mine. I try to put everybody that's on a JAK inhibitor to get the Shingrix vaccine. And it is okay to use these with other biologics and other DMARDs. TB testing, I do it prior to or at the time of initiating a TNF inhibitor. I repeat it 3 to 12 months later or when they change, because there is, in the United States, which is a non-endemic region with a low risk, there's a 10% chance that people who are once negative truly are positive, have latent TB, and when you correct their inflammation, you'll get a true positive back, whether it be by PPD or by IGRA, whichever one you like to use. Again, I think that's about, doing it annually is just plain goofy and stupid. You're really not supposed to do repeat TB testing unless risk changes. They're exposed or to someone who has TB, or they travel to a very high-risk area. The dermatology guidelines say they do it annually, and now we're dealing with insurance companies that are asking for an annual TB test on people. If you were doing skin testing, you would turn a lot of those people, not a lot, a significant minority of them, into positive PPDs by doing repeat annual PPDs. You won't do that if you do IGRAs, but I don't like giving in to stupidity. So, and again, if you are going to give a live virus, that's the rules. Be off for 4 weeks, wait 2 weeks before you restart. Let me stop there and take any questions you may have. Thank you very much.